Good evening, everybody, and welcome to this evening's Concussion, a Primer for GPs webinar. My name is Samantha and I will be your host. We are joined by our presenters this evening, Associate Professor Antonio Dieva and Dr. Rowena Mobbs, and our facilitator, Dr. Tim Senior. Before we jump in, I would like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past and present. Okay, I would like to formally introduce our presenters for this evening now. Associate Professor Antonio Dieva is a consultant neurosurgeon with 18 years of experience in brain and spine surgery. He's an associate professor at Macquarie University, full professor of neurosurgery in Italy, and associate professor of neuroanatomy in Austria, with main interests in neuro-oncology and TBI. Professor Dieva is an Australian Research Council Future Fellow and Head of Computational Neurosurgery Lab at Macquarie University. Dr. Rowena Mobbs is a cognitive neurologist with over a decade of experience in managing behavioural and cognitive changes in dementia and patients with mild traumatic brain injury. She has a PhD in cell death in compressive myelopathy. Rowena leads the dementia and concussion clinics at Macquarie Health Neurology, working within a multidisciplinary team. She's passionate about concussion prevention and management. Rowena is appointed to Macquarie University Hospital as senior lecturer and is visiting neurologist at Mater Hospital. And our facilitator this evening, Dr. Tim Senior. Tim is a GP at Tharawal Aboriginal Corporation in southwestern Sydney. He's also an RACGP medical advisor for the National Faculty of Aboriginal and Torres Strait Islander Health and senior lecturer in general practice and Indigenous health at UWS. So welcome Antonio, Rowena and Tim. And I will hand over to Tim now, who is going to take us through our learning outcomes for this evening.
Thank you very much, Sammy. Good evening, everyone. I hope you're all keeping well and looking after each other. So these are the learning outcomes this evening. I'm at home and there's big night road works going on outside my house. So if you hear all sorts of strange noises, it could well be that. Just let us know if the sound's awful. This is what we hope to achieve tonight, learning outcomes, which is educational speak for what we're going to get out of tonight. So by the end of this activity, we should be able to classify concussion and traumatic brain injury with special attention on the physiopathological mechanisms related to concussion. We should be able to utilize the sport concussion assessment tool, characterize signs and symptoms related to concussion and its management. We should be able to be aware of the importance of neuroimaging related research. We should be able to institute immediate headache management pathways and coordinate care. And we should be able to identify risk factors for headache disorders and cognitive overlaps post-head trauma. So I'll hand over to Associate Professor Antonio Dieva.
Good evening, everyone, and thank you very much for a nice presentation. Thanks, Tim, and thanks, Sam, and thank you, everyone, for being here at this hour. I would like to introduce you to this universe of concussion. Which is a multidimensional universe in which useless to say that the general practitioner is the central hub of a network, which is a very complex network formed by several physicians, surgeons, and healthcarers. From the historical perspective, it's quite interesting that I was looking for the definition of a concussion in this book published in the 1535. And this is the first book in which there is a definition of neurotraumatology and management of trauma and traumatic brain injury. And of course, there is no real clear definition about concussion. Although the author of this book, Berengari Da Carpi, was defining some symptoms which are related to minor head injury, like headache, dizziness, which are something which could be related to concussion as we know it nowadays. So in terms of definition, we use some slides to define it. Concussion is a brain injury and is defined as a complex pathophysiological process affecting the brain induced by biomechanical forces. So concussion may be caused either by a direct blow to the head, face, neck, or elsewhere on the body with an impulsive force transmitted to the head. Concussion typically results in the rapid onset of a short impairment of a neurological function that resolves spontaneously. However, in some cases, symptoms and signs may evolve over a number of minutes to hours. Concussion may result in neuropathological changes, but the acute clinical symptoms largely reflect a functional disturbance rather than a structural injury, and as such, no abnormality is seen on standard structural neuroimaging studies. This is a very important point that we discuss later on in terms of neuroimaging when neuroimaging is requested. Concussion results in a graded set of clinical symptoms that may or may not involve loss of consciousness. Resolution of the clinical and cognitive symptoms typically follows a sequential course. However, it is important to note that in some cases, post-concussive symptoms may be prolonged. So in this slide, you can see the definition of traumatic brain injury, and you well know that the most used scoring system is the Glasgow Coma Scale, which scores between 3, which is the minimal score done because 1 point is given to each domain of analysis, which is the motor response, the eye response, and the verbal response, and to 15, which is the maximum score. According to the GCS, we can classify traumatic brain injury as a mild TBI when the GCS is scored between 13 and 15. This is related to post-traumatic amnesia, generally lasting less than 1 day, and if there is a loss of consciousness, this is between 0 and 30 minutes. A moderate TBI is defined when a GCS is between 9 and 12, and the severe TBI is between 3 and 8. Of course, this is a patient in coma with who in general has a PTA longer than 7 days with a loss of consciousness more than 24 hours, because of course the patient is in coma. The problem is that where is the concussion over here? And there is not a very well standardized way to define, to use the GCS in concussion, because there are other definitions that GCS of 15 can be defined as a minimal TBI. The problem is that concussion, and in general concussion is the one related to sports because it's the most typical one, although concussion can happen also in falls or in other kind of injury. In this case, the sport concussion falls between a minimal and a mild Glasgow Coma Scale, because remember, this patient can have a 15 GCS, but could also have a 14 because maybe loses a score, 1 single point, because he's confused when you ask something. In terms of epidemiology, concussion in sport has been reported between 0.1 and 21.5 cases every 1,000 athletic exposure, with the lowest incidence in swimming and diving, and the highest one in junior ice hockey and American football. Of course, this shows that is clearly a North American phenomenon for this kind of sports and also for the population living over there. And by the age of 10, 1 in 5 children, this means 51,000 children in Australia, will sustain a concussion and present with acute post-concussion symptoms. So these Canadian studies shows that concussion and mild traumatic brain injury is very well represented in kids, especially before 14 years of age. In regards to physiopathology, there are quite interesting research aspects which can justify the symptoms that we see in these patients. Unlike more severe TBIs, the disturbance of a brain function from concussion is related more to dysfunction of a brain metabolism rather than structural injury or damage. The current understanding of the underlying pathology of a concussion involves a paradigm shift away from a focus on anatomical damage to an emphasis on a neural dysfunction involving a complex cascade of ionic, metabolic, and physiological events. Clinical signs and symptoms of a concussion, such as poor memory, speed of processing, fatigue, and dizziness, result from this underlying neurometabolic cascade. In animal and human study, MTBI can alter the brain physiology for hours to years, setting into motion a variety of pathological events. As in one example, in some experiments on animals, after an initial increase in glucose metabolism, there is a subsequent reduced metabolic state which may persist for up to 4 weeks after injury. Though these events are thought to interfere with the neural and the brain function, the metabolic processes that follow concussion are reversible in a large majority of affected brain cells. However, a few cells may die after the injury. Cerebral blood flow is relatively reduced for unknown reasons, so it looks like a kind of ischemia, of course much less relevant than ischemia itself, but this loss of glucose can also cause a kind of an energy crisis, and the vasospasm in the small vessels can cause migraine and headache. which is the topic which will be discussed by Dr. Rob Mobbs later on. Along with this process, the activity of mitochondria may be reduced, which causes the cells to rely on anaerobic metabolism to produce energy, increasing the levels of lactate. So if you see, the concussion can involve neurons as well as glial cells. And the concussion can release some biomarkers from these cells in the cerebrospinal fluid as well as in the blood. So, of course, in the last years, we have looked for specific biomarkers of a concussion. And here there is a synthesis of the most known biomarkers coming from the body of the cell neuron, or from the axon, or from the glia cells. But the important thing is that we are trying to quantify these biomarkers and relate it to concussion, but unfortunately there is not a really translational clinical application so far. So it's more in the research setting. Evaluation, signs and symptoms are the somatic symptoms, like for example, headache, cognitive dysfunction, like a feeling like in a fog, or emotional symptoms like lability. Physical signs include loss of consciousness and amnesia. Some behavioral changes have been reported, like irritability or cognitive impairment, like slowed reaction times. Moreover, there are sleep disturbances sometimes, like drowsiness and insomnia. On-field or sideline evaluation of acute concussion when a player shows any feature of a concussion is a very, very important thing, because these should be evaluated by a physician or other licensed healthcare provider on site, using a standard emergency management principle, and the particular attention should be given to excluding a cervical spine injury. The appropriate disposition of the player must be determined by the treating healthcare provider in a timely manner. If no healthcare provider is available, the player should be safely removed from practice or play and the urgent referral to a physician arranged. Once the first aid issues are addressed, an assessment of the concussive injury should be made using the SCAT-5, which is the assessment tool we'll see later on in the next slides. The player should not be left alone following the injury, and the serial monitoring for deterioration is essential over the initial few hours following injury. A player with the diagnosed concussion should not be allowed to return to play on the day of injury. This is the most important point. So the SCAT-5, the Sport Concussion Assessment Tool, has been done by an assessment of experts who agreed to put together this test. And the last one is the version number 5 of 2007. It's important to understand that first of all, the SCAT-5 can be is designed by physician, for physician and licensed healthcare professional. It takes time, not less than 20-30 minutes in general, so it cannot be done in a correct way in less than 10 minutes. And if there is no physician or healthcare professional, the sport players or the people around should use the Concussion Recognition Tool 5, the CRT5. Moreover, another important point, the SCAT-5 has been designed for athletes aged 13 years or older, whilst for children aged 12 years or younger, please, you should use another version, which is the child SCAT-5. In the next slides, there are some examples you can download for free on the website here in the PowerPoint presentation. And you can see that if you read the instruction, it's impossible to be wrong on following the SCAT-5, which is 20-30 minutes long, but it's not that difficult. So the step one is recognizing red flags, because if there are one or more of these red flags, like a seizure, convulsion, double vision, weakness or tingling of the arms or the legs, these are worrisome things that could suggest that this is something more serious than a concussion itself. There are the step two, the observable signs, if you have witnessed the signs, or for example, you saw a video or someone else told you. There is a memory assessment with a very quick and easy question about memory. There is the quantification and the scoring system of the GCS by means of the scoring between 3 and 15 on the 3 different domains. And here there are the domains. And there is the cervical spine assessment, which should be done always, because it's very important to assess if there is also cervical injury. Later on, there are some background information to be taken by the physician, and this is not just epidemiological information about the athlete, but also other things like if he already had a concussion in his life. And the step 2 is a symptom evaluation. It's very important to understand that this is given to the athlete. So the athlete takes this part in his hands or her hands, start to read loudly the first paragraph over here, and later on start to assess all these symptoms, if there are or not, headache, pressure in head, neck pain, and things like that, scoring in a subjective way between 0 and 6. And this is an assessment which can be done in baseline, for example, before the concussion, before playing, or post-injury. When the test is done and is given back to the physician, and the doctor can check the number of symptoms between 0 and 22, and the severity score, which is scored between 0 and 122, scoring the maximum score for each domain, for each symptom. Later on, there are some other steps in the cognitive domain. The cognitive screening includes the orientation questions, some memory questions about some words to be remembered and repeated over time, and other tasks like the digits backwards and months in reverse order. This domain is just to check the concentration. And again, these things can be scored with a yes or not if the patient was able to give the number or the months in the reverse order. This is specifically by the GP, because they have to check the neurological function, if there is a dysfunction from the neurological point of view, or even checking the balance examination. Last but not least, there is the delayed recall, in which the doctor is asking the athlete if he remembers the words which were repeated before, and this gives the last score. At this point, there is the decision part, in which the doctor is putting together the severity of symptoms and the number of symptoms, and all these is just to put together an evaluation. Remember that there is no score which is a cutoff to decide if the patient has a concussion or not. The scoring on the SCAT should not be used as a standalone method to diagnose concussion, because this is more a follow-up method which is designed to give to the athlete a concussion injury advice. So trying to understand if the concussion was there or not, giving some recommendations like avoid alcohol, avoid sleeping tablets and things like that. And moreover, trying to have a quantitator to be compared in case the patient shows up again with some worsening of some symptoms. And so the SCAT baseline, the first concussion, or after a few hours or a few days, can easily depict which domain is more affected and where the management should go. Remember that the SCAT-5 is for doctors and for health carers. So if there is no doctor, this is a much easier version in which basically everyone can ask these kind of questions and assess the level of concussion. In an emergency room or office by medical personnel, the SCAT-5 can be still given to the athlete, but of course we can do many more things like checking gait and balance, and eventually deciding even if neuroimaging is involved, is requested or not. So the investigation, let's remember that if you ask for a CT scan, is because you are really suspicious of something more serious, like a fracture or some brain swelling, or some facial injuries. So basically the take-home message is that the CT scan does not give any information at all on a simple concussion. Unfortunately, even the MRI is not able to depict any information. Remember that MRI is able to depict some microbleedings, for example, and but a normal concussion has no structural changes in the brain itself. This means that the metabolic change happening in the brain after concussion cannot be depicted in a structural and architectural MRI, for example, T1 and T2 sequences. So basically, this MRI most likely will be negative. Having said that, you ask for an MRI if you suspect for or you find a focal neurological deficit, there are some worsening symptoms, or prolonged disturbance of a conscious state. Having said that, there are a lot of research tools like a functional MRI trying to quantify and characterize the connectomes of the brain if there are some specific features which could be related to concussion. And there are other technologies that we'll see in the last slides about the research aspect of a concussion. Moreover, there are other investigations like, for example, the balance error scoring system, if the doctor, especially sports physician, have a force plate technology, they can quantify and characterize the balance of the patient. The eye tracking system can be used by checking the visual movement of the eyes, the saccades, or other tests can be given, like the King-David test. And there are other experimental things like genetic testing and markers. For example, the apolipoprotein E4 has been related to some dementia and cognitive disturbances. And some people have this genetic mutation might have a higher susceptibility to the outcome after a concussion. This might justify why simple concussion affect some people more than others. Of course, also this is a research tool because there is insufficient evidence for routine clinical use. Neuropsychological assessment is something important which should not be done alone, but the neuropsychologist can check the baseline and the difference after concussion, and eventually can also check if there are other baseline problems like depression, for example. So the management. Remember that the concussion is in general self-limiting and benign problems because the majority of concussed people, almost up to 90%, resolve in a short time or less than 10 days. But this time can be longer in children and kids. The first cornerstone is a physical rest, no training, playing, exercise, and weights, especially the day of the concussion itself. And there is a cognitive rest, and which is very, very important, especially for kids, like no television, extensive reading, or video games. But there is a question mark here because there is not a very strong evidence if the cognitive rest is really recommended in kids in order to recover faster. So the expected gradual resolution is in less than 7 days, and 7-10 days. It's very important to try to understand how the patient or the kid will be able to return to school or to play again. So the return to play strategy has to be used, and we see a slide about that. In terms of pharmacotherapy, we use drugs and medication just for prolonged symptoms, or just to help with the sleep disturbances, anxiety, or headache, for example. But other modifiers like antidepressants should not be used at the beginning because this could mask some important symptoms related to the concussion. So you ask the patient if he feels well, and if they feel fine or not. They can quantify that maybe they don't feel really 100%. In that case, you ask why they don't feel 100%, and you can give again the SCAT5 to see what's the domain they're losing at some points. This is a very pragmatic way to understand when the athlete or kid or concussed patient can go back to or return to play protocol. Imagine that every one of these is a tier in which there is a stage, no activity, with a functional exercise and an objective. So in tier 1, there are no activity at all, and if the patient is able to have a very good recovery for doing nothing, the day after can start some light aerobic exercise, doing some walking, swimming, and trying to increase the heart ratio. And if he passes this tier, can go to sport-specific exercise, and so on. So if you see there is a 24 hours per step, and in total in 5-6 days, the patient should be able to return to play or to return to school. If the patient gets stuck in one of these tier, in this step, he has to be there until he does not pass the objective. And this makes a little bit longer the recovery itself. So the only thing we are really sure with some evidence is that the same day return to play, the answer is not, because one concussion is a problem, but more concussion are major problems, especially when they happen in a very short period of time. And the patient can come back to play if he remains asymptomatic, if he's confident to go back. And there are the questions, should he use a helmet or headgear? And there is not a lot of evidence about that. The problem starts when the patient has symptoms for a period of time longer than 10 days. So we're talking about 10, 15 of these patients. In this case, the multidisciplinary concussion clinic is very, very useful because this patient is a much more complex patient who has to be managed in a multidisciplinary fashion. So neurologists, or neurosurgeon, or other healthcares can help in the management assessment of difficult concussion cases. Again, the psychological assessment can be important in that case because the psychologist can assess the multifactorial problems related to the baseline of the patient, or if the problems are related to the concussion itself. Remember that there are some modifying factors, which are factors which can modify the management, the decision-making, and the prognosis. For example, symptoms factors. If there are a lot of concussion, or the concussion lasted more than 10 days, or they were quite severe, or if the patient had some loss of consciousness longer than 1 minute, these are all modifying factors which give you a lower threshold to have a much more aggressive management of the concussion itself. Related to that, there is the big topic of the chronic traumatic encephalopathy, because it looks like that more concussion can cause some precipitation of proteins, which look like the tauopathy of Parkinson or Alzheimer's disease. Unfortunately, we don't know that much, because the only way to diagnose the CTE nowadays is just doing a brain autopsy. So we don't know the real incidence in athletic populations. But of course, this is a big deal, because especially when in the rugby league some decades ago in the States, there was a little big discussion about this entity which was not recognized in earlier age. In terms of prevention, we don't know if the protective equipment helps for concussion. For sure helps to avoid facial and head injury and TBI, but about concussion, we are not sure if an helmet can really help. Sometimes a helmet can even facilitate some grades of concussion. And there are other issues to be considered, like changing the behavior on the playground, like, for example, avoiding aggression and violence, promoting fair play and respect. In terms of research, I already mentioned some tools that we are trying to use, like functional MRI, which is an image here. There is a lot of research in terms of biomedical engineering, because we are trying to understand if helmet help or not, or which kind of device could prevent the problems related to concussion. Or we use in the research setting EEG and magnetoencephalography, and these give us some information about the connectomes of the brain. We use sometimes also the eye tracking, as I mentioned to you before, or advanced imaging to check the stiffness of the brain, how the brain tissue amplifies the waves after concussion, or how the molecule of water move in the axon in the brain, to see if there is a difference after the concussion. And this imaging is called the DTI, diffusion tensor imaging, which is a quite advanced MRI, which is used nowadays for concussion, but again, it's a much more a research aspect than a clinical translation of things to be done every time. So there are some references here you can find useful to keep going in detail with this topic. And my acknowledgements go to several people, but especially to Dr. Michael Cusimano, who was my supervisor during my skull-based fellowship 3 years long in Toronto, who opened to me not just the world of neuro-oncology and skull-based surgery, but also this universe of concussion from the clinical point of view and from the research setting. Thank you very much.
Okay, so an approach to headache. So this is a really common condition, as Antonio has well spoken about, and also we would recognise that many people have had a concussion. If you ask patients and spend the time, many of them have quite some number of years of exposure to repeated head trauma. So I think it's a very important issue, particularly as children may be more affected, and the elderly and females. So we need to really all work together to understand this condition more and look closely. It's not necessarily a mild traumatic brain injury as far as the patient's experience. Of course, it can be quite impactful for their life. So we have set up a concussion clinic at Macquarie now to help work in an interdisciplinary fashion and do some more research. There's been $50 million released by the federal government towards further traumatic brain injury research, and we're certainly happy to be part of that effort if we can. And so concussions can be sustained in many ways, as we've talked about. Falls can occur, particularly in conditions of Parkinsonian nature that I would see, such as Lewy body disease or Parkinson's, in epilepsy, or misadventure, of course, and we're perhaps seeing less sporting concussions recently with the pandemic and more of these other sorts. Military comes to mind, of course, particularly blast injury, And we're typically talking patients who have experienced over 1,000 impacts if they're involved in a blast situation. This is a video we'll send you the link for. It illustrates a convulsive or seizure concussion in an ice hockey player, and this is of course one of the sports of key focus for traumatic encephalopathy syndrome and chronic traumatic encephalopathy changes at autopsy. And we have very little literature really on the meaning of convulsive concussion and what that means as far as outcomes. That more work could be done in this field. Recently, there was a convulsive concussion for the rugby league, and this was the response in the media. We'll give him a good 10-day break and he'll be right. And I find this a little along the lines of the old attitude of, come on, get up, son, you'll be okay. And I think players are increasingly aware of that attitude and keen to look after their own health, but also the community are looking at grassroots levels and what we can do better in a coordinated fashion, and maybe even mandating some changes to ensure that we look after these patients very well. So headache is of course an intrinsic part of concussion, but also post-concussion syndrome. And I have to admit, the vast majority of my concussion patients will be beyond that 2-week period into the post-concussion phase, just by nature of referral. Concussion is accounting for approximately 80% of all traumatic brain injuries, so very, very common. The loss of consciousness does not have to occur for a post-concussion syndrome to evolve. And the severity of the TBI at the time doesn't necessarily correlate with the severity of post-concussion symptoms. These symptoms are complex and common, and they're very individual. Each concussion experience tends to be a little different, with headache, dizziness, neuropsychiatric symptoms, and cognitive impairment. I've mentioned the vulnerable patients, so female sex, older patients, and the paediatric population are more susceptible to greater frequency of concussion and severity. And there's a whole field of neurology opening up with neurohormonal research as to these sorts of vulnerabilities. The recognition of PCS in children can be difficult. It's typically defined, again, arbitrarily as symptoms beyond 4 weeks, but eliciting what those symptoms are in a young child, of course, may be difficult. Most are mild. Most commonly we see post-concussion headache or post-traumatic headache in the mild TBI, but of course moderate and severe TBI patients can have that as well. We see it in whiplash, so there may be no direct impact to the head. And in fact, 20% of whiplash patients have cervicogenic pain evolving to migraine. And the pathophysiology is likely structural, but also biochemical and neuroinflammatory. And there's some really exciting work looking into this worldwide. Here is one of these studies. So this was a study looking at the biomechanical effects of head impact, looking at the oscillatory changes that occur. So with oscillations in the order of 20 to 40 hertz, the brain is more vulnerable to injury, like a bell ringing. And so it's not just a contre coup, 1-2 insult, it's that repetitive vibratory effect on the brain. Of course, there may be torsion and other effects. Post-concussion syndrome is greatest within 7 to 10 days, but it may extend well beyond that. So the majority of patients have recovered by 3 months, but I think a large number, really, 10 to 15%, have symptoms beyond 1 year. So there's a lot of work to be done in the management of these patients. I typically use a post-concussion symptom scale as one of my guides. In those who have a score beyond 13, there's a much higher rate of post-concussion syndrome that will extend beyond the month. So it can be a bit of a guide, and you can test that longitudinally for patients. The headache syndromes are variable. Around, well, studies vary widely. 1/4 to 3/4 of patients will have a headache syndrome after concussion. Paradoxically, the headache prevalence, duration and severity is greater in those with mild head injury than more severe, as we've mentioned. Pre-existing headaches are an ongoing risk factor for headache after trauma. The onset of headache should typically be within 7 days, but really a 3-month latency is more likely. And my own feeling is that maybe headache syndromes can be triggered months down the track after significant levels of head trauma. The International Headache Society classification identifies subtypes after concussion that are similar to non-traumatic headaches. Migraine and tension headaches predominate the number of these patients' syndromes. Tension is the most frequent. 3/4 of patients have that type. But in blast injury, migraine may be more common, and many patients have more than one type of headache overlapping. For tension, this can vary widely. Most of us have experienced a tension headache. It can be bitemporal, bifrontal, generalized, unilateral, constant or intermittent, typically associated with increased stress or screen time or late in the day. There may be dehydration, but there may be a degree of migraine overlap. It's thought that tension headache and migraine do have the spectrum. There can be a dull pressure or a tightness, a tight band typically. And we need to be aware always that analgesic overuse can occur in up to 40% of post-traumatic headache actually, such as Panadol or codeine use. So ensuring a drug holiday is important. For migraine headache, well, this can vary widely. So many patients believe that a headache is a severe episode of vomiting in a dark room, but it's way more varied than that. It may be generalized, or it may be lateralized, or very focal, like a watery effect and a focal sharp pain. It can come on very quickly, almost immediately. It doesn't have to gradually come on. There can be a pounding or throbbing nature, photophobia, but also phonophobia, the sensitivity to sounds, which is more common in the Asian population. Dizziness or disequilibrium, typically. You can have a migraine syndrome post-trauma of pure disequilibrium without other features. Nausea, vomiting, lethargy, and mental clouding. So here comes the cognitive impairment aspect and overlap with migraine. So lethargy and mental clouding are extremely common in chronic migraine, if not some of the most common symptoms. So treating those is important for sorting the wheat from the chaff. And you'll see the post-concussion symptom scale there. The symptoms of concussion themselves and post-concussion are very similar to migraine. So it's really about good empiric management. So here is a typical MRI from a migraine patient where you would see specks of tiny white matter hyperintensities in the frontal regions typically. And these are thought not to have a clinical significance other than to associate with migraine. That being said, I must mention that migraine has an association with stroke, as you will know. And if you're a smoker, that's in the order of 34 times increased risk. So that's an important question to follow up with patients. What is migraine like? Well, these are some of the quotes from patients. So they've tried many types of medications. Nothing has helped. They've often gone on for decades and not really realising that they were migraine, just thinking they were headaches and suffering in silence. It's affecting their work, their life. It's greatly debilitating, and they just may not realise the options out there. So really important to recognise both for the person and economically. Migraine can occur with or without visual aura. So these are the typical scintillations or bright sparkles, fortification spectra, which are the zigzags. You might get central scotoma, and you may get tunnelling or just simple blurring or obscuration. There can be severe pain and nausea and vomiting. Migraine is thought to have strong genetic elements. Often these patients, particularly with post-traumatic migraine, will have a family history. It may be the mother or the father. I'm yet to really understand the literature, but it would seem that often on the father's side, there may be a more severe migraine syndrome. Migraine can extend to the brainstem and cerebellum, and there may be significant disequilibrium and the nausea and vomiting, of course. Recurrent attacks can result from the mild head injury, particularly if you have 2 concussions in a row. And the head or cervical impact itself can, of course, directly trigger pain. Pain can lead to tension, which might lead to migraine. It's usually multifactorial. It was originally termed footballer's migraine, but of course, this occurs in any contact or collision sport. Other headache syndromes are seen. The TMJ dysfunction can be due to direct trauma or jarring, and you can get an ipsilateral hemicranial pain resulting from that. Many patients have bruxism, and so you might want to treat this as part of their headache management. Occipital neuralgia can occur from a direct blow to that region of the skull, causing aching, pressure, stabbing. And in fact, there's evidence of treating that in chronic migraine, let alone treating occipital neuralgia, and you would arrange a perineural occipital injection typically and get them to avoid massage. They often try to massage the area, and that may damage the nerve further. There can be direct trigeminal nerve injury, particularly to supraorbital or infraorbital branches, with a shooting, allogenic pain, tingling, aching or burning, paroxysmal or constant. And of course, at the site of a soft tissue injury, you can have pain there, tingling and shooting pain that can persist despite apparent healing of the wound. Some patients, very rarely, might have a low pressure headache from CSF leak due to a dural root sleeve tear or a cribriform plate fracture. You might ask about anosmia. There's a prominent positional association with this, so it's fine when they're supine but severe when upright, and identical to a post-dural headache. Cortical contusions can have pain, much like stroke, but this is variable. It might be a typical generalized ache, and if it extends to the subarachnoid space with a hemorrhage, then there can be severe pain. Traumatic dissection can occur, remember, so I always typically order an MRA from the arch to the circle of Willis, alongside MRV for any venous thrombosis that can occur in trauma, and a good MRI with temporal views. We look at SWE imaging too for any microhemorrhage changes. And there are case reports of cluster headache and also autonomic dysfunction, a particular syndrome called SUNCT, which is rare, occurs in women mostly. They typically brace the unilateral head pain and brace, and there's tearing associated with that. It's a case of extremis lasting for hours at a time. Sleep is really important. So sleep disturbances are common. Remember to look for PTSD. Insomnia occurs in about a third of patients in the acute phase after TBI. They can be hypersomnolent, have an insomnia, increased sleep need overall. But also we can see weight gain and depression associating with obstructive sleep apnea, or OSA contributing to migraine full stop. And there can be bruxism, of course, with the trauma of the event, increased anxiety around their loss of return to work or life, and other factors. So I typically would look at a PSG or sleep study. Dizziness occurs in about half of patients with concussion. It's non-specific often. It might be lightheaded or disequilibrium or a true vertigo. And I've seen patients with a functional neurological disorder in this circumstance, a conversion disorder. So consider that as a possible diagnosis. Around 25% of neurology patients have an overlap with FND. Complaints of dizziness at the time of injury and afterwards are often associated with more prolonged recovery. Psychology. So more than half of patients have a mood or affective disturbance. They're intolerant of noise, they get emotional rushes of emotion or excitement and difficulty handling crowds, for example. They can be more susceptible to alcohol effects. And their family members report that they're quite irritable or more withdrawn or just not themselves. 15 to 20% meet the criteria for a psychiatric disorder, such as PTSD or acute stress. And of course, overlaps of PTSD in veterans are common. So cognitive rehabilitation has been looked at, particularly in defence. It's a little controversial, but overall, the results are fairly promising, but it's costly and it takes expertise. In one study, 15 patients with mild TBI who met the criteria for depression were treated with sertraline. And there was a substantial remission in depressive symptoms, so this may have a role. And like migraine, providing a serotonergic environment could be helpful. CBT has been looked at, and again, this may be helpful. When do I need a neuropsychologist? We've touched on this. When it's getting a little complex and when you suspect there might be Cognitive overlaps, this could reflect a possible traumatic encephalopathy syndrome or a more severe spectrum of TBI tending towards moderate, mild to moderate, or mood disturbance or even fogginess of migraine can occur. So it helps us really define which areas of the brain are affected and in what way. It gives that player a very good baseline going forward. So I would typically look at this in the months after a head injury if they haven't resolved. In one study, 15% of patients had persistent cognitive deficits, and it can be very similar to psychological illness, pain and medication overlaps. Age and baseline are considered, but not all of the testing for this is well standardised. So we take it a little with a grain of salt and in the context of their other investigations. Pharmacotherapy is important, of course, particularly if you're looking at managing migraine. So amitriptyline has been looked at directly in post-trauma with some evidence for resolving features. Propranolol or amitriptyline in combination can be helpful. Topiramate, valproate, Lyrica, Sandomigrant and Candesartan have a rather sparse literature for post-traumatic headache. The triptans may be helpful, a Panadol-Nurofen combination or high-dose aspirin. And the newest kid off the block is the CGRP antagonist, which directly blocks one of the receptors on the trigeminal nerve and alters vascular response. And this has almost as good evidence as Botox in migraine and could look promising for post-traumatic headache. An inpatient program of metoclopramide and intravenous dihydroergotamine can be helpful, but that's quite an intense approach. And the occipital nerve block is up the sleeve to try. Okay, we've got to be wary of analgesic overuse, as I've mentioned, and indomethacin can be helpful too, particularly in coital headaches. In one study looking at Botox for post-traumatic headache, or those with a history of MTBI in the military, there was a response. 64% of patients reported feeling better, but further studies are needed. And this is some of the work that we're looking at Macquarie. The non-pharmacotherapeutic management is so essential, providing education, basic education around concussion and post-concussion syndrome. Helping to involve family members in that support, a multidisciplinary team. And this has some evidence in the studies, of course, for providing better outcome. There are conservative approaches of gentle neck massage, and we involve the physiotherapy team, Chris Wynn at MQ Health for this, looking at B vitamins as a group. B vitamin preparation can be of assistance, involving neurology, looking at MRI, and then we work with a team, including neurosurgery, ENT as appropriate. Many patients have tinnitus overlaps to their syndrome. I'm co-director at the Australian Sports Brain Bank, so we're really interested in not only sports-related exposure to concussion and subconcussion, so they're the head impacts without symptoms, but also in sports and the non-sporting environment, the military, in farmers or those handling livestock, and in falls, for example. So we're working with RPA at the Sports Brain Bank, and we're studying these patients in life with neuropsychology, neuro-ophthalmology and imaging. So it's worth mentioning too that some patients have a very prolonged syndrome after concussion. This may involve a functional overlap. There's usually very prominent emotional symptoms associated with this, and the risk factors for this small group of patients remains unclear, but no doubt a team of support in the long term is needed, and at the very least you're there to help listen and counsel your patients, of course. So in summary, just a few pearls. Post-concussion syndrome and headache disorders are common, and they're complex in their constellation. They require individualist care. Specialist care may be useful. Women, children and older patients are more susceptible, and they present their own unique challenges. So a team with experience is important. The severity of the brain injury does not correlate with the risk of developing PCS, nor the prognosis. So I think there may be a role for more standardised follow-up for at least sporting concussion. And there are many theories on the structural and biochemical brain changes, and I think we'll gain some good insights over the next decade or two regarding this. It's quite an exciting time to be in this space. So I'd like to thank everyone here tonight, and also thank my team. Antonio is there, Jennifer Batchelor is our neuropsychologist on the team, Alan Pearce in neurophysiology, Claire Fraser for neuro-ophthalmology, our neuropsychologist in imaging, and Michael Buckland at RPA as well. So thank you very much, everyone. And I'm happy to answer questions.
Thank you very much indeed. You've done a fantastic job getting through a lot of information, both of you, and thank you for answering some of the questions that came through in the chat box as well. Those are our learning outcomes there. We have got a bit of time for questions still, so there's 2 questions currently available. So I invite either of you to answer. Would the treatment for post-concussion migraine, is it any different to typical migraine? And the question in terms of medication, but I guess that's also in terms of non-medication management of migraines as well.
Yeah, so I guess I'll answer that. Thank you. So look, it's very similar. The only thing I'd be a little wary of is the very somnolent patient or the very mood disturbed patient that you may see in a post-concussion syndrome versus migraine. Of course, it can occur in migraine, but I'm very passionate about offering migraine therapy for these patients because I think it can make a difference. There's evidence it can, and we should, the proof is in the pudding. So trialing these medications carefully, starting low, going slow, but certainly offering that range of therapies is important.
Excellent. And there's another question which I think you answered in your presentation as well about Botox injections in managing migraine headaches and how helpful that is.
Yes.
Nerve blocks.
Yeah, so I think Botox is really our best evidence therapy. It's been around for decades now, not just years. It typically can improve over 2/3 of patients for chronic migraine. It's well tolerated, very localized, and patients, may find that more easily adherent than, say, taking a medication routinely. And the other issue too must be raised of using medications in sports. So of course, things like propranolol, the beta blockers, or sedating medications may not go too well on the sporting field, or in those sports requiring shooting, for example, in pentathlon. So just got to pick and choose a little bit. But I think Botox would be our #1 treatment in migraine.
Yeah, excellent. We've got a question from a participant who's been doing exactly this sort of work this week. She's had 3 patients present with tinnitus and hearing loss post-head injury. So she's sending them for formal hearing tests, but anything else you'd recommend in those circumstances?
Yeah, so I think it's essential to work with the ENT specialists on this. So there can be overlaps with Meniere's disease. So we're always heightened to that, in which case you'd look at a low salt diet and some antihistamines such as satir, and stress management, as well as close ENT watch. Of course, there can be structural injury to the ear, so that must be excluded with specific views on MRI and specialist review. Yeah.
And I would add also a CT scan, because, I spoke against the CT scan, but sometimes CT scan comes back as a useful. For example, if there is a hearing loss, I would like to do a skull-based high-resolution CT scan to see slice by slice, 1 millimeter thick, if there is a small fracture on the petrous bone. And this information can be very, very useful for the ENT surgeon as well.
Right, indeed, yeah.
Yeah, thank you. That's really helpful. There's a question that came through earlier that you answered by text, but I'm not sure if everyone saw the answer. I think that's potentially important for everyone. If the patient's already on antidepressants and then sustains a concussion, should that be withheld or continued? And I think that's a useful thing for us to know about.
Yeah, so given depression can overlap from the actual brain injury perspective, of biological depression, neurobiological depression, plus the situational depression and reactive changes by being out of their sport or out of work in these typically highly achieving individuals, I would continue the SSRI or the SNRI with expectation that would need to be maintained and not stop it, because certainly there can be a withdrawal syndrome that could mix the picture, muddy the waters for a post-concussion assessment. They could have a reactive depression if we did that. However, there are the exceptions of amitriptyline and mirtazapine if the patient is somnolent. You might consider a careful down titration or cessation. I guess with mirtazapine, paradoxically, it can be less sedating on 30 milligrams rather than 15, so you might even consider a dose up if they need it. But evidence in migraine for a serotonergic state that can assist the actual headache syndrome. So I think we should try to continue those if we can.
Excellent, that's helpful. We've got a question. Does a history of previous concussion increase the risk of concussion with milder head injuries in the future?
Well, I think a approximate concussion, no one really knows the answer to that, but say within a few months of your last concussion, but particularly within a fortnight, can lead to more severe and more prolonged symptoms after the second concussion. Does that help answer?
Yeah, I think it's a very big topic because we know that the time phrase is very important because it's a metabolic problem in which neurons are trying to recover and to try to reduce the lactate. So if there is a second concussion in a very short period of time, you can increase the neuronal death. Having said that, sometimes concussion coming even after days, weeks or months or years, some people are more susceptible than others. And in this case, of course, we don't know an answer, but could be related to some genetic susceptibility. I was talking about with, for example, some genetic mutation in the APOE4. So we don't know. There is a lot of research about that. For sure, having more concussion in a short period of time is something very bad, but also in a very wide range of time could be a problem. We don't have a clear answer about that.
Wonderful. Was there any more questions, Tim, or is that wrapping us up for the evening? Was there any more you wanted to field?
There's probably just one quick one. Do non-invasive stimulators have a role to play for these types of headaches, especially in children?
Antonio, I defer.
I'm not sure what's about the non-invasive stimulator.
Yeah, we might get back to you on that question. So,
yeah.
Just looking at another. We've had a few. We've had a few comments come through, which I think we all recognise about the that tension between what we know to be the best management of concussion and head injuries, and the pressure that players and sports clubs feel to get people back playing and be pretty tough. There's a few comments around that, I think, and we all recognise that tension. And my understanding is that they're moving towards a better understanding, but it's certainly not perfect yet at the moment.
I would like to just comment that I think there's a community shift occurring of more awareness around the importance of looking after your brain in order to be the best player you can. And I think people are being more careful.
Yeah. I agree. I think
just read the comment about the stimulators. So we're talking invasive stimulators. So we do neuromodulation for pain. So supraorbital stimulators sometimes can be used. And I agree with that. For example, Dr. Mobbs mentioned the block of the occipital nerve for occipital neuralgia. That block, if it fails, can be still can be just the previous tier to a neuromodulation of putting a stimulator on the occipital nerve. So I agree that one of the last tier of a treatment can be neurostimulation.
Excellent. Thank you very much. So on your screen now is the learning outcomes from tonight. So if you look through those, hopefully we've achieved all of those for you. We've had a few people asking about whether we'll get the slides, and those will be sent to you sometime after the webinar this evening. I'd like to thank very much our speakers this evening for an excellent session on concussion. And Sammy, over to you to close for the evening.
Wonderful. Thanks, Tim. And I would just like to reiterate Tim's message and thank Antonio and Rowena again, and also yourself, Tim, and everybody who joined us online this evening. We do hope you enjoyed the session and enjoy the rest of your evening.